So our next speaker is Fauzia Paize, who is from the Liverpool Women's Hospital, and she's a consultant neonatologist and Jacob's mum.
Thank you so much, everyone. I just wanted to say, I really love public speaking, but I really hate podiums. Because I'm tiny, and can you even sit? Am I just a floating head? But if I stand here, you can't hear me, can you? Can you hear me at the back? If I shout? Because, this isn't a good look, is it? I'm going to stand here. Right, thank you very much for the introduction. You can't take a photo of me now, can you? Do you want me to stand here for a second? Is this going to go on? If it's going to go on Twitter, I'll stand here. No, I'm Fauzia. I am a consultant neonatologist in Liverpool, and I'm also Jacob's mum. My first baby was born at 23 weeks. He was stillborn, and it suddenly opened up. I was already a trainee in neonatal medicine at the time, and it opened up this whole world that I just didn't know existed. And as a trainee, you would see an empty incubator space after a baby has died, and you think, oh, that's very sad. And then you would just move on, and within a couple of hours, there'd be another baby there. But suddenly I was that person who had to deal with the aftermath of all of that. And so that has definitely influenced the way that I work. And I'm just going to tell you a little bit about concentrating on multidisciplinary antenatal and perinatal palliative care and the advanced care planning that we've started doing in Liverpool and has tried to spread it across the Northwest. So like I said, when people get pregnant, they are expecting, we're all the Facebook, Instagram generation. We post our bump pictures, we post our scan pictures, we talk about, people go along to their 12-week scan to know when they're due. They go along to their 20-week scan if they are to find out if they're having a boy or a girl. They don't go along to be told that there's a really significant problem with their baby. They certainly don't go along to say that be told that there's no heartbeat. So it's a massive life-altering change in expectations when something goes wrong in pregnancy, because we don't talk about it, and we're just used to the fact that people get pregnant easily, stay pregnant, go home and have a baby and take their baby home. What they're not going to expect is this picture here. Neonatal units aren't that crowded anymore, but they don't expect all the bells and whistles of intensive care. They don't expect their baby to be absolutely tiny in an incubator. They don't expect that their pregnancy has suddenly been cut short and they didn't get that massive baby bump they were expecting. And what they certainly don't expect is a really sad piece of memory making that's all they're left with from their pregnancy. So just a bit of background statistics. About 80,000 babies are admitted to neonatal units every year. 1 in 10 pregnancies end up with a baby on a neonatal unit. We still don't talk about it. I think that's a massive figure. Around 2,000 neonatal deaths are due to causes likely to require palliative care. We're a lot better at this, but probably about 5 years ago, still about 98% of neonatal deaths occurred on a neonatal unit, and we weren't even talking about trying to get these babies out to have their care elsewhere. And actually a lot of the planned extubations that we did were at the cot side with other babies in the room. I'm going to tell you a lot about how we've moved on from all of that, but very few were supposed to die at a hospice or at home. The prevalence of life-limiting conditions is the highest in children under the year of 1, and then it decreases through the age bands. And actually, your biggest chance of dying at any stage in your life is in your first 28 days of life. So this is a really vulnerable population that needs a lot of support and a lot of help from healthcare professionals to support parents through all of this. The definition of palliative care is up there. I think palliative care is all about choice. I know that's the theme of the day, but palliative care is all about maximising the time as a family together, because that time can be really short. And it's all about us as healthcare professionals offering that choice to families to be able to say, you may just have a few hours with your baby. What do you want to do? So these are the kind of babies that will pitch up who might require perinatal palliative care. By far, for me, in my working practice, the easiest group of babies are those who where something's detected antenatally, and mainly because that gives us time. It gives us time to make plans. It gives us time to figure out what the family's priorities are. It gives us time to offer support to family members, grandparents, parents, grandparents, siblings, to try and get everybody on board as to this horrendous journey that they're now going to have to go on instead of the normal pregnancy that they were expecting. So chromosomal problems, babies with Edwards syndrome, babies with Patau syndrome, those are chromosomal problems that lead babies to have very, very short lives. Cardiac anomalies, significant hyperplastic left hearts, the heart completely plumbed in incorrectly, so that it's very difficult to sustain life with that. Central nervous system problems, babies with anencephaly or other brain malformations that will lead them to not have much time after they're born. The babies that we tend to forget are these two groups here, because a baby born at 23 weeks on a neonatal unit who has been resuscitated has palliative care needs. Even though we are very, very good in intensive care at talking about life-sustaining and medical treatments, we need to have in the back of our minds, this may not go to plan, and what are we going to do if this baby dies, and how are we going to support this family? Also goes not just the extreme preterm babies, but the term hypoxic ischemic encephalopathy babies, or something happening around the time of birth that has been very traumatic for that baby and has made that baby's transition to ongoing life very difficult for it. That baby also, even though we are throwing everything we have at intensive care at that baby also has palliative care needs, and that's all about parallel planning, which is I'm also going to get to. Postnatally, very, very occasionally, maybe once or twice a year, we will get a baby who has been born and has made that transition through birth fine, and then something starts happening quite soon after it's been born, usually overwhelming sepsis or persistent fetal circulation, which means that the baby is not getting enough oxygen to its body. Those are, again, a couple of groups where babies may require palliative care needs. I'm not going to go over all of these, but it's just to say in the last 10 to 15 years, we've had more and more publications in our area, which is really, really great. And it means that we're being taken seriously as a clinical group. So lots of publications about trying to improve the provision of perinatal palliative care. So what are the goals? Like I said, support for the family after the diagnosis of a fetal condition, which may mean that the baby has a particularly short life. And it has to be within a really close-knit, well-functioning, multidisciplinary team. I was involved in the NICE guidelines that was on the previous slide, and if any of you pick up the NICE guidelines for paediatric palliative care, it's meant to cover babies as well, but they didn't use the word baby enough in the whole document. And I was trying to stress with them how I think that this group of patients have very specific healthcare professionals around them that a child at home doesn't necessarily. So we have midwives, bereavement midwives, we have neonatal nurses potentially, we have fetal medicine consultants, obstetricians, whereas later on down the road you sort of lose some of that, and those teams need to work really closely together to be able to get this right. The purpose of the multidisciplinary team should be medically to make a diagnosis and to try and estimate a prognosis for that baby, which is sometimes nigh on impossible. The number of times I've said to couples in the fetal centre, I do not know how your baby who has a diaphragmatic hernia, I do not know how their lungs are going to function after that baby is born. I've seen babies go off to have their surgery done and fly off ventilators and be fine, and I've seen babies who die within an hour of birth, and I don't know which one. Even though we can do measurements, you don't know how those lungs are going to function once that baby is born. So it's really, really important to develop a sensitive birth plan, even though it may be, so the example of diaphragmatic hernia, there 50-50 chance of survival for those babies. You're going to hope you're in that 50% that's going to get there. A lot of babies do go off to surgery, but if that doesn't happen, what are we going to do? And so a sensitive birth plan for everyone involved is really, really important. And preparation for the entire family. And there's still some work for us to do with that, but we're not great at supporting grandparents. We're not great at supporting siblings. It's a very isolating thing when something goes wrong in pregnancy, and sometimes the people around you don't get it either, so they can sometimes be a hindrance instead of a help, and so we need to help that whole family unit understand what's going on. And parallel planning is the crux of perinatal palliative care. So a baby who has problems with their kidneys. So if your kidneys aren't functioning when you are developing, then your lungs don't function, because you need that urine production to produce the fluid that sits around the lungs, and the lungs need to move in and out so that breathing is developed in utero, and that breathing pattern develops the lungs. If you don't have well-functioning kidneys, that doesn't happen. However, you don't know to the like I said about the diaphragmatic hernia, we don't know to the extent that that baby's lungs have been affected. So plan A for a baby when they're born with a bilateral renal cystic dysplastic kidneys is we do nothing, because the lungs might be so severe that we've decided that you want to meet your baby, and we do nothing in the delivery room in terms of medical intervention. Obviously, we provide cuddles and lots of supportive care. Put a tube down into their lungs is plan B, to see how well their lungs inflate. Plan B would include, if the heart rate doesn't come up soon after they're born, then we stop and we move to palliative care, we move to cuddles in the delivery room. Plan C would be, we're going to throw everything at this baby, and we're going to do intubation and emergency umbilical lines and resuscitation drugs, and try to get to the neonatal unit. Plan D then is, though, to carry on talking about it, is to get to the neonatal unit and then to see how well those lungs are functioning. And if after a couple of hours our SATs are still in the 30s, 40s, then we need to stop intensive care. But the preliminary discussions with that family still need to include what would happen if that baby gets to the tertiary paediatric hospital, and the discussion about ongoing dialysis and transplantation in case it is one of the babies that can do well through this. So each of those, it takes a long, long time, but it needs to be done, because each of those eventualities needs to be discussed, planned for, written down, and discussed with the whole team, and be available so that the whole team, when this baby pitches up anywhere at birth, knows how to access that detail and knows how to treat that baby and that family when that baby arrives. So really, really important to have lots of MDT discussions and documentation, writing it down. And what's the most difficult, because a baby doesn't have its own set of case notes before it's born, sometimes that can be really difficult to make sure that the information is in a place where everyone can access. So what's our role? Our role is to determine a diagnosis and make the best estimate of a prognosis, determine all relevant medically appropriate and legal and ethically acceptable options. This is what we don't do enough, elicit the family's philosophy. So what we do is we talk about the medicine loads, and we're really good at talking about the medicine, but how is that impacting on the family, and what can we do to help that? And you don't know that until you ask. We need to ask, how is this affecting you? What support do you need? Would you like us to do anything else for you? And ensure that a clear plan and explanation of what will happen at delivery and the first few days, and address the physical, social, emotional and spiritual support that is required for that family. There are lots of challenges in perinatal palliative care, and I'm still in that position where people are, shy away from it in terms of making a robust plan for these families. And there's a lot of diagnostic uncertainty, so that means that time together might be really, really short. And because the time could be really, really short, that's why we need to make all of those plans to be able to make sure that we're delivering the best care that we possibly can for these families. Babies' conditions can change really suddenly. So for any of you who've worked on a neonatal unit, I know the majority of you are student midwives, if I'm right. Babies can be fine 1 minute on a ventilator and then suddenly have had a cardiac arrest and die. And we need to be able to plan for that potential eventuality. So all babies need to have some kind of discussion about what's going to happen if plan A and B don't work. There may be multiple births. One baby might be anencephalic and the other baby's well, and that whole pregnancy surrounds itself around the baby who's unwell. And we sometimes forget about the baby who's well and growing and thriving, and it must be horrendous to have that delivery and then be completely torn between a baby who's dying and then the normal basic feeding needs of a baby who is there as well. And so that makes it potentially difficult. Mothers can be really unwell, so I'm sure a lot of you looked after preeclamptic women. They can be really, really sick, and that then leads to the first few hours after a baby is born to be particularly difficult for everyone to manage. Partners, we do forget about the dads, don't we? Or the mums. So we're not very good at partners. We're not very good at supporting, because I think it's because the mother's notes as the, that has everything in it, and there's the mother's case note number on everything, and they're the patient. So I think we then sort of forget that there's this other person around in their life, and so for us, the fathers who whether the baby's been delivered and is sick because the mother's had intensive care needs for herself and is in a different hospital, and then their baby's requiring intensive care for us. Those are the fathers that are just deers in headlights, and they do have their own significant needs. Like I said before, there are different healthcare teams involved for us, and new parents are tired, they're emotional, they're hormonal. It's a very difficult time of birth, and that's why I think it's a very, very specific niche group compared to a lot of the other spectrum of palliative care that you go on to with children and adults. Like I said, those are the difficulties, and what are the barriers that we face? We don't talk about it, do we? We don't like talking about babies dying. That's not something that happens, and so if it doesn't happen in our life, then we're not going to talk about it. That then doesn't help support families when they're going through something horrendous, because their own network of people may not be the best at helping them. There's still confusion that palliative care is hospice is death, and like I said at the beginning, palliative care is maximising your time as a family, and how are we going to do that? It's not necessarily about death. A baby with 23 weeks has got better and better chances of survival over the years, so we do concentrate on the intensive care aspects, but we also need to start memory making from early on in that baby's journey, just in case something goes wrong. We see death as a failure in healthcare, and we don't spend enough time thinking about the potential of that baby dying and what we can do to try and make that journey a bit nicer for families. And we do focus on life-prolonging treatments more so. And there's no evidence. Whenever I go to conferences or I speak at conferences about this area, and usually the people before me have got loads and loads of forest plots and other randomised control studies that they've done in areas looking at which ventilator is the best for babies, and then I stand up and I go, I've got nothing. There's no randomised study even looking at doses of morphine to use for palliative care for babies. It's just not there. It's not a sexy thing to fund, so there's not a lot to base our work on. What can we do? You're doing it right now, being in a room, talking about this, learning about this, taking it forward into your clinical practice and sharing it with your colleagues. We're still not great at the whole world of baby loss, and that's the reason that you're here, to try and improve it, and it's fantastic to see a room full of people so devoted to it. Close MDT working and documentation. Documentation is really, really key, and communication. Things being handed over properly, the parallel palliative care plan being handed over properly, that the baby hasn't delivered on my shift, this is what's going to happen when the baby is delivered, the neonatal team know this. That's the kind of thing we need to be talking about. I'm going to talk a little bit about children's hospices a bit later, but by far the best thing in my career that we've instituted at the Liverpool Women's Hospital is an integration of our local children's hospice services into the neonatal unit. So they come in and they do a ward round with us once a week. They support families antenatally, they support siblings, they support grandparents, they have baby drop-in groups for people who've delivered with baby with a life-limiting condition, so that they don't feel uncomfortable going to another baby group. They are amazing, and if you go forward in your careers and start talking about children's hospices, and they're free, not to them, but they're free to us. Promote open discussions as part of the environment of care. Parent education. I do think that we should mention to parents during their antenatal care that some babies end up on neonatal units, and some babies don't make it. And there are probably nice ways to put that. And I know we assume that pregnancy leads to babies and going home, but it doesn't. And I think we should start as a society to introduce more of that into our antenatal care. And national awareness raising, which I think has grown more and more over the last sort of 5 years. So this is part of parallel planning. This is parallel planning is absolutely hoping for the best, but this is what we're going to do if that doesn't happen. We give this in a leaflet to families who are on delivery suites who are in preterm labour, and we talk about there's going to be a team in the room, they're going to resuscitate your baby, there's going to be a tube put down into their lungs, we're going to give surfactant, your baby will be put into a plastic bag, we'll keep them warm, you will have a cuddle, and then we will go to the neonatal unit. But we leave this leaflet with them if we have time, just so that they have an idea that their baby may not survive, and they know that. And I can't imagine any baby who is born at 23, 24, 25 weeks in an incubator, loads of tubes and lines in, and those parents aren't sat there thinking, my baby might die. So it's okay for us to mention that as well. Yes, your baby might die, and this is what we will do to help you with that. We are doing everything we can with intensive care, but this is what we're going to do to help you if that doesn't happen. I'm just going to quickly go over this. It's the Northwest Fetal, it's basically an antenatal advanced care plan. So an advanced care plan is something that you plan with a family with palliative care needs as to what to do with certain eventualities if things are moving more towards end-of-life care. So it's a document that's to be kept in the maternal notes, and it's basically what it does is it tells you the kind of things. So a lot of fetal medicine services are regional, so you could be booked in Wigan but go for your fetal scan in Manchester and have problems picked up there, but you may want to deliver in Wigan, or you may go into labour early and end up delivering in Wigan because even though you were booked in Manchester. So it's important that something is held with the family to say something has happened in my pregnancy and this is what the plan is. So the specific plan for immediately postnatal care talks about monitoring in labour, the extent of the planned resuscitation. That's really important for us and the family because we might put a tube down but not give emergency drugs because that might not be the right thing for the baby because they've already shown that through the labour process they haven't handled that particularly well and that their outcomes are then going to be even poorer. Possible treatment, the action plan in resuscitation, the care in the delivery room, comfort care measures. I've met so many families who've said, I don't want intervention for my baby, but I'm terrified of them dying and being in pain. So we will talk to them about that and say there are drugs that we can use, your baby's not going to be in any pain, they're going to be in skin to skin, they're going to have the best time that they could possibly have in their short lives, but we will help with any medication that we need to. And then options for hospice or home care. And then, like I said, what are the priorities for this baby and the in terms of memory making, photography, casts? Do they want a naming ceremony? Is it important for them in the first couple of hours of life that somebody comes in and does a christening for them? Which family members do they want around? Which family members do they want us to keep away? And are there any specific spiritual or cultural needs at the time of the infant's birth? We only have one chance to get this right. There's no do-overs. You have to make really good plans for these babies and families, and they have to be delivered with great care and compassion and communication. And communication must be clear. It must be consistent. We need to be on the same page. And like I said, there's so many different healthcare teams involved when babies are born. That can sometimes be really difficult. But that's why you need to spread the word of good bereavement care with baby loss, because it's so important that we get this right, because the things that you remember when something hasn't been done properly lasts a lifetime. And you just need to think, how would you want people to behave with you? I'm not going to go, you can't see this, you're not meant to be able to see this, but I'd like to promote checklists. I mean, I'm an intensive care consultant, so I love a good checklist or a flow chart to tell you what to do, but we have an end-of-life checklist for babies who have been ventilated and are moving towards end-of-life care. So we're going to take that tube out. And it involves where are you going to provide that care? How are you going to get them to that place? Are the parents going to carry them? Can they go in a cot? Can they go in a pram? Because that's the only time they're ever going to be able to push their baby. Do they want to go home to have that tube taken out? Do they want to go to the beach if that's what we can do? Do they want to go to a children's hospice to be able to take that tube out? If you don't have all of these prompts in some kind of document, then you forget to offer all of those choices to families, because some of these choices are easier. Our transport team isn't great at facilitating babies to go home. That doesn't mean I don't keep poking them to say this family wants to go home. How are we going to achieve that? It reminds us to give cabergoline for mothers who sometimes have been producing milk for weeks. It reminds us to offer those women the chance to donate that breast milk if they want to, if that's going to be helping part of their healing process, to know that they've helped other babies. I just can't stress it enough how using a checklist for your end-of-life care or for your memory making, how important that is. This document also, I'm not going to go over this too much, but it was produced a couple of years ago, and it's a perinatal pathway by Together for Short Lives. Together for Short Lives is the main children's palliative care charity, and this is the first time any document was produced that talked, in all of those documents that I showed you, none of them mentioned antenatal care. This is the first document that started to talk about antenatal care and parallel planning in the antenatal period. So if you get a chance to pick it up and read it, that would be great. Just a few other things about acknowledgement of loss. We know from lots and lots of research, qualitative research, that parents want some acknowledgement of the loss of their baby and to be able to remember that baby. And one of the few areas of good research that have been done in terms of baby loss has been by Newcastle, who started doing a lot of work with twin pregnancies or triplet pregnancies where one of the multiple pregnancy babies died. And people, you would hear stories about nurses wiping off twin one from the board, going, oh, you don't need that anymore, do you? Because they're not a twin anymore, when they are clearly still a twin. Or people saying, oh, where's the other twin? Are they in room 2 when twins died? And so to prevent those kind of horrendous bits of communication, Newcastle developed this butterfly logo, and it's for multiple pregnancies, and it's there can be cot cards or there can be stickers. We turn them into stickers. There's a space just underneath the butterfly to put the baby's name of the baby that died, and we use it antenatally. We use it if one baby has died in utero antenatally. We use it on the ends of cots after we've spoken to parents, obviously, to signify that this isn't a singleton pregnancy. It's to be on on the postnatal wards with one baby when you're expecting 2 is horrendous. And so to be able to acknowledge that in some way, we use the butterfly logo. We also use the baby loss awareness logo on cots. So if there has been any pregnancy loss of any kind, one of my other bugbears in life is the hierarchy of pregnancy loss. It does my head in. A 6th miscarriage at 7 weeks, that's not as bad as a term stillbirth. How do you know that? How can you determine that? That's not up to us to determine. So any pregnancy loss gets, again with the consent of parents, gets signified to the rest of the healthcare teams that this couple have had a really horrendous journey and they need support from us. We're obviously nice to everyone, but we just give them a bit of extra support and space if they're not dealing with something particularly well. Our hospital bereavement team are called the Honeysuckle team. So any family that has experienced a baby loss will leave the hospital with a tote bag with a Honeysuckle logo on, and the Honeysuckle logo is advertised across the hospital to signify baby loss. So if you see a couple in the corridor who are crying or who are trying to find somewhere and they're carrying one of these, then we know that couple needs a little bit of extra sensitivity and support, and we should be kind to them. We should be kind to everyone, but we should be kind to them. And we put the butterfly logo up when there's end-of-life care going on, or a baby is dying in one of the rooms, or we have an end-of-life suite, then the butterfly logo goes on there as well on the neonatal unit, so that it's quite near the entrance to the neonatal unit. So if you're coming in on shift, you're allowed to be happy and chatty and talking to the people that you're coming in shift. But if you walk in and you suddenly see that logo, you're quiet because you're being respectful as to what is going on behind that door. The grief that is associated with baby loss is really, really lonely because people don't know what to say to you. So sometimes they don't say anything at all. And we don't expect our babies to die. So it can be a really lonely thing. So people, if their babies die quite quickly after they're born, sometimes there hasn't been time for other family members to come in and see that baby when they're alive, sometimes on the neonatal unit. Or we're getting much better at, because we use cuddle cots now and we facilitate people taking their babies home or to a hospice, that there may be a chance for more people to come and visit their baby, but it is a lonely process. And there can be a lack of appreciation that what happened during delivery and the emotional roller coaster that these families are on. So it's our jobs to be that support for families. It's our jobs to make sure that we are their extended family for that period of time, to be able to give them that support that they need and say the right things. We've only got one chance. Children's hospice support. So just a model of care for, I really can't stress enough how great Clare House, our local children's hospice, has been to parents and families on the neonatal unit. Any baby that gets referred, that gets an antenatal diagnosis, gets referred straight to to Clare House. They meet the family, they will go to antenatal appointments with them, they will support siblings and be with them when things are being explained to them, they will support grandparents. They then visit the family again, so the initial referral can be at 20 weeks at the 20-week scan, then they will carry on supporting them, and we make a clear written plan at about 26 to 28 weeks. I've told you those things. One of the great things about their service is that they have really good bereavement support following a baby's death, and counselling services for everyone who wants to access it from the family. So we have limited counselling services from the NHS. They have a whole raft of people who they can refer people onto, or within the counselling, within the hospice they will have counsellors as well. They run mother and baby groups. They have complementary therapies for people. They're really a massive resource that we've tapped into, and we initially thought it would be a bit like walking around with the Grim Reaper behind you on a ward round, but it's not like that at all. We introduced them as Clare House, and they're here to support families who are having a difficult time, which is true, and their families have really warmed to them and welcomed them into their lives, and have utilised them for a lot of support. They will be there at births. They have been there at births and have been on call for a lot of families that go through the fetal centre have planned caesarean sections, but they have actually been on call for births, for natural births as well. So they are amazing. So please look into your local children's charity. This is my last slide. So I think about 10 years ago, we were really good or bad at talking about curing. We'll throw all intensive care at this baby and make sure that we get them home. Oh, I'm really sorry, it's all gone wrong. I'm sorry they've died. And what we've been better at is this. We've been better at talking about the curative medicine, but also talking about what we're going to do if stuff doesn't go well. So babies who get admitted to the neonatal unit get hand and footprints done, all babies, within the first 24 hours. The first nappy change that families do, we facilitate them doing the hand and footprints so that there's something to remember if it goes wrong. They all get a journey box. So they get a memory keepsake box for when they get admitted to the neonatal unit to save SATS probes and NG tubes and anything else they want to save. And that's memory making without them really realising it, because if everything goes well, then great, take your box home and remember all your journey, the horrendous journey that you went through on the neonatal unit, but you did it. If your baby dies, that gets converted into your memory box. So it's to encourage them to start making memories for themselves. We offer casting. We have been doing some casting on babies who haven't just died, some of the bigger babies on the unit, and we encourage photographs and videos to be done as soon as babies are on the neonatal unit. So we're much better at introducing the idea of this might not go as well as planned earlier on in the baby's journey. But what I'd like you to take away is the fact that, like I said at the beginning, bereavement and loss surrounds the whole pregnancy and the whole time on a neonatal unit when something has gone wrong at 6 months, 8 months into a pregnancy. It ties in with the loss of that pregnancy, not just the loss of a baby, if that makes sense. Oh, that's not me. Okay. That's it. Thank you very much.